Welcome to today's webinar, Common and Uncommon Health Conditions in Adolescents and Adults with Down Syndrome. My name is Laura Crone. I'm the Project Manager for Research and Education at the Adult Down Syndrome Center in Park Ridge, Illinois. We are a healthcare clinic for adolescents and adults with Down syndrome, ages 12 and older. Since opening in 1992, our healthcare providers have seen over 6,000 patients with Down syndrome. In addition to providing patient care, we offer a variety of research and education opportunities, such as this webinar. Next slide, please. Our presenter today is Dr. Brian Chicoine. He is the medical director of the Advocate Medical Group Adult Down Syndrome Center here in Park Ridge. He is also on the faculty of the Family Medicine Residency at Advocate Lutheran General Hospital. He received his medical degree from Loyola University of Chicago Stritch School of Medicine and completed his family medicine residency at Lutheran General Hospital. In 1992, Dr. Chicoine co-founded the Adult Down Syndrome Center. He has provided medical care for adults with intellectual disabilities for over 30 years and has presented and written extensively on caring for adults with Down syndrome. Before I turn it over to Dr. Chicoine, I do have a few reminders. Next slide, please. The webinar is being recorded. The link to this recording and the slides from the webinar will be emailed to everyone who has registered for the webinar within about 1 week. There will be time for Q&A at the end of the webinar. Please submit questions using the Q&A option in the Zoom toolbar. We will try to get to as many questions as we can at the end. Next slide, please. And lastly, please note that the information in this presentation is for educational purposes only and does not take the place of working with your own healthcare professionals. And with that, I am going to hand it over to Dr. Chicoine.
Thank you very much, Laura, and great to be here with everybody. So we want to talk about common and uncommon health conditions in adolescents and adults with Down syndrome, and we want to provide an overview of those conditions and then describe some differences in how frequently some of these health conditions occur in people with and without Down syndrome, and then discuss a comprehensive and individualized healthcare for these individuals. So as you probably know, people with Down syndrome are living longer and healthier than any time in the past. And this is a graph of life expectancy in years. And I use these dates because in 1907, I had a great uncle Leo that was born, and he had Down syndrome, although that's not what they called it at the time. And his life expectancy was only 8. When I graduated from medical school in 1984, the life expectancy of people with Down syndrome was about 28. And now more recent data in 2018, it's upwards of 60. And these are numbers for individuals with Down syndrome that are Caucasian, and so the little lower for people of other races, but this is the commonly quoted information. So you can see that really through the course of my medical career, from 1984 on, the life expectancy has more than doubled. I don't take credit for that, but you can see that there's been quite a change just really within a couple generations. So it's an amazing how much the life expectancy has changed in a relatively short period of time. And much of that has to do with the ability to treat congenital heart disease. About 50% of kids with Down syndrome are born with heart defects, and really into the late 70s, early 80s, it was not possible to treat those individuals well. And now that's dramatically has had huge impact. There are other factors, but that's probably the main one. So in addition to living longer, there are a lot more adults with Down syndrome living now than ever before. I say that when I was in medical school, I got about 5 minutes of training on caring for adults with Down syndrome. And that's probably a 5-minute exaggeration. I honestly can't remember anyone talking about adults with Down syndrome in medical school. But in their defense, there weren't that many adults with Down syndrome back in the early 80s. So this is changed dramatically. And you can see from this study done by Dr. DeGraff and others, this is U.S. data, that it's estimated there's about 210,000 or so people with Down syndrome living in the United States as of 2016. And more than half of them are age 20 and older. And so you can see how back in 1950 all the way to the left, you can see how few of those individuals were in the older age range. And so not only are there a lot more people with Down syndrome, but there are a lot more adults with Down syndrome than there ever were before. So as this population has increased in size and increased in life expectancy and age, what are some of the health conditions that we now need to really attend to? Excuse me. So we had and we'll show some of the data from this, but we were able to look at over 6,000 people with Down syndrome that were served in our healthcare system and compare them to 30,000 plus individuals that did not have Down syndrome, but were matched basically for gender and age. And we'll show some of those comparisons. And then we did some follow-up reports and kind of a deeper dive into some of the mental health conditions, infectious conditions, and endocrinology conditions. And we'll talk a little bit about that here in a second. And then the other piece of information that's come out in the last several years is the medical care guidelines for adults with Down syndrome, excuse me, sponsored by Global. And that's really the first evidence-based recommendations intend to offer guidance for healthcare providers who see adults with Down syndrome. And there was an article published in the Journal of the American Medical Association that is available. And so that information is available in the links that the link you see there. So I encourage you to take a look at that. And we'll talk a little bit about some of that information. I should add that, really this guideline project is really looking to provide guidance from head to toe, if you will, for people with Down syndrome. And so the first round, I call it, is not a complete guide. There are additional topics that need to be covered yet. And we are now actually in the second round and looking at some of the additional topics. One of the topics that actually was not included in the first round, but is in the second round, is the issue around cancer and cancer screening. We know that leukemia, primarily in children with Down syndrome, is more common. Excuse me. And testicular cancer in boys is more common in people with Down syndrome. But interestingly, most solid tumors, breast cancer, cervical cancer, colorectal cancer, colon cancer, is significantly less common in people with Down syndrome. And so if you look at the data from our study, breast cancer, if you look column just to the right of breast cancer, it says Down syndrome. And so that's the number of cases we had out of over almost 6,100 people, so about 0.16%. And then in the age-matched population that did not have Down syndrome, there was about 246 cases, or about 0.81%. And then if you look more or less, so breast cancer is less common in women with Down syndrome. And if you look at the odds ratio, and that means comparing the frequency in people with Down syndrome compared to the frequency in people without Down syndrome, in this case, women, obviously. And so is, 0.20, which means about a fifth as common in women with Down syndrome compared to the rest of the population. Cervical cancer, similarly, significantly less common. Colorectal cancer, less common. Testicular cancer, actually, as I mentioned, is more common, as is leukemia, as you can see there so testicular cancer being more than 2.5 times more common, and leukemia being more than 4 times more common in people with Down syndrome. Again, leukemia primarily in children, not so much in adults, although we've had a few cases of adults develop leukemia in our practice over the years. So how does cancer present in people with Down syndrome? So one of the issues is that with many conditions that we see, that a certain percentage of the population that we serve of people with Down syndrome are not able to self-report what they're experiencing, what they're feeling, based on their communication skills or ability to assess themselves. And so the lack of self-report sometimes can be challenging, and we have seen some individuals present with one gentleman, for example, with testicular cancer, that something that had gotten significantly large, and he was not reporting. And so the lack of self-report was certainly impacted on the assessment and the treatment ultimately. And therefore, it may present later due to that lack of report that the person is not feeling well or that there's something not right. And again, sometimes it may present with a behavioral change. If the person's not feeling well and they're not able to say, "I don't feel well," it may be displayed with a behavioral change. But otherwise, the presentation is pretty similar that you would expect in someone with and without Down syndrome. But we do have a pretty limited experience with solid tumors. Excuse me, because they're so much less common. And as far as leukemia, we do have limited experience because these primarily present in children, and we sort of, start at age 12. And so we don't see often the littler ones that have developed leukemia. We have seen a number of individual men develop testicular cancer. And again, the presentation is pretty similar, although the lack of self-report is something that we've experienced. As far as treatment for cancer, the treatment recommendations are generally not different, although in one kind of cancer, or I'm sorry, one kind of leukemia called AML, it's been found that lower doses of the chemotherapeutic agents work equally as well, but reduce the side effects. And so actually the success rate is better when the doses are lower, is one thing that's been found. And then the screening question, how might the screening be similar or different? So let's talk a little bit about screening and why that might be different. So one thing to consider is that the risks and benefits might be different for individuals with Down syndrome. So if something is very uncommon, it may not make sense to be screening for that. And if something is more common, it may be making sense to screen for a person with Down syndrome that you might not screen in somebody else. So really how frequently these things are excuse me, how frequently these things are occurring in individuals makes a big difference in whether you may or may not want to be screening for them. And so really, one of the things we consider is the shared decision-making with the person and their family or their caregiver and their doctor. And so we want to look at what is the prevalence of the condition. So is the condition the same or more or less than it is in somebody else? If it's less, is it a lot less, or is it just a little bit less? And is it so infrequent that it maybe screening for it maybe doesn't make sense? How old is the person with Down syndrome? And that's not unique to Down syndrome. That's true for any of us. There are screening guidelines for lots of conditions, including cancer in the non-Down syndrome population, that at some age range, above some range of age, the recommendation is to no longer screen because the likelihood that the individual will get benefit from screening is reduced because their life expectancy is not enough that they would get benefit from the screening. And what does the procedure involve? So even not only just the screening test, but then also what are the follow-up procedures involved? So again, if it's, a screening is just a simple blood test, but if it's abnormal, it requires scanning or biopsies or whatever the case may be. What are the implications for that? What are the potential pitfalls, or what are the potential complications of doing those, either the screening test or doing the follow-up tests? And then is anesthesia required? We know, unfortunately, that people with Down syndrome have more risks with anesthesia. And if anesthesia is required for a person with Down syndrome to do either the test or the follow-up test, does that increase the potential for complications and potential that the screening may not be as the risk of the procedure, the screening may be great enough that it exceeds the benefit. And those are all questions that have to be answered individually and based on the individual's own health issues. And then the last question is, what is the family history? We know that family history impacts many kinds of cancer. If you have a family history, you're more likely to get the cancer yourself. And so what does that mean in a person with Down syndrome if there's a family history of these cancers? And unfortunately, for most part, we don't really have those answers for people with Down syndrome. And in a way, I look at it as what is the genetics? What is the impact of the genetics of having an extra chromosome, having Down syndrome, versus the family genetics? And for the most part, we don't really have an understanding of how those two factors weigh into the care of or screening for someone with Down syndrome. So a lot we're still learning. But let's just take a look at breast cancer, for example. So we had the good fortune of being part of a study that was done a computer model for breast cancer screening. The computer model that was part of the information that's used by the United States Preventative Task Force on screening recommendations for women in general. And so several years ago, the recommendation by this organization agency was that women without Down syndrome, or women in general, should be screened for breast cancer starting at age 50, and then do a mammogram every other year. And that was the recommendation based on the data that they had. And so they're actually now looking at reducing that down to 40, although as far as I know, as of the last time I checked a few weeks ago, that official recommendation has not been made. But nevertheless, they're looking at considering reducing that to 40 every other year, starting at 40 in the population. But anyway, so at the time that our study was done, the recommendation was to do it every other year, starting at age 50. So in women without Down syndrome, it took about 2,200 mammograms on this breast cancer computer model to avoid one death from breast cancer. And it took about 27 biopsies to avert one breast cancer death. But in women with Down syndrome on this computer model, it took almost 17,000 mammograms, 17,000 women getting mammograms to avert one breast cancer death. And it took about 209 biopsies to avert one breast cancer death. So again, trying to weigh in, we do know that many women with Down syndrome who need a breast biopsy have to have it under general anesthesia in order to participate in that process or that procedure. And we do know that the risk of complications of anesthesia is greater. And so ultimately, is it safer to proceed with the screening, or is it safer not to, basically? And so this is the data that we have so far. And so those are all conversations that are important to have with your doctor with regards to whether proceeding with the mammogram is the right thing to do or not. And so those are just some of the that would be part of that decision, the mutual shared decision making, I should say. And so those are all. There's no official recommendation against getting mammograms at this point in women with Down syndrome. But again, we do know from the data we have that the benefit is probably much lower because breast cancer is less common in women with Down syndrome, and the risk may be greater because of the potential for anesthesia, and so in anesthesia complications. And so those are discussions to be had with regards to, is the benefit still enough, as it would be in the rest of the population, to warrant doing a mammogram. So just a case study, an example, a 42-year-old woman came in for an annual physical. And so we did the history and the physical exam and the screening labs. And then we had a discussion about mammography. And again, knowing now that they're looking at reducing the United States Preventative Service Task Force, talking about reducing it back down to 40. And other organizations do use 40. So it kind of depends on which organization's recommendation you're looking at. So we had a discussion about family history and what are the risks and benefits, and then ultimately the individual with Down syndrome and their family made a decision about whether or not to get a mammogram. We're going to shift to mental health. So we talked about cancer, and now we're talking about mental health. So we do know that some of the mental health conditions that are more common include depression, obsessive compulsive disorder, and impulse control disorder. Uncommon would be substance use or abuse. We see very little of that in our practice. And then we've talked about, at least in our data, we found that generalized anxiety disorder and post-traumatic stress disorder were less common, although I think that there's a reason why that's probably not correct, and I'll share that with you in just a second. We think those are actually probably more common than our data showed. So if you look again, we go back to our study, and depression was about 1.25 times more common in people with Down syndrome. Anxiety overall was a little more common, about 1.1 times more common. But you see the generalized anxiety and the post-traumatic stress disorder were less common. But obsessive compulsive disorder, which is related to anxiety, was significantly more common. And then you can see substance abuse was quite uncommon in our practice. And so, why did we see that anxiety and post-traumatic stress disorder, which we suspect are both more common in people with Down syndrome, why did we see that they were less? And we suspect because with mental health, it's again sometimes difficult for people to self-report symptoms, and we'll talk about that in just a second. And so really it ends up being what we're basing diagnosis on is observable behavior. And so oftentimes we see that when people with Down syndrome get anxious or they've had a traumatic event in their life, their behavior becomes more compulsive. And so what we're seeing, rather than them reporting that they're anxious or being able to report a traumatic event, what we end up seeing is that their behavior becomes more compulsive, and that's how that either anxiety or stress manifests. And so we think that's probably why those numbers are skewed the way that they are. And certainly other studies have indicated that anxiety and post-traumatic stress are probably more common in people with Down syndrome, and we suspect overall that's the case as well. And then other things to think about would be mental health conditions due to physiologic or physical problems. And that's certainly something we see significant amount, and we'll talk about that in just a second. And psychosis more common. And then impulse control disorder, significantly more common. And if you look at scans of the brains of individuals with Down syndrome, where we have impulse control, that part of the brain has some differences in people with Down syndrome. So that's not to be unexpected based on neuroanatomy, the anatomy of the brain. Not insurmountable, but certainly, but a challenge nevertheless at times. So why do we see some of the differences in presentation, for example, as talking about with the anxiety and the post-traumatic stress? So one of the reasons is again to go back to the communication issue. And so again, the people's individuals' ability to self-report, what they're feeling sometimes is excuse me, is difficult for some people with Down syndrome. And so sometimes it'll present as a behavior change rather than a self-report change. And I like to say that any and all behavioral change should be considered as a possible communication tool. So the person may not be able to communicate with their words, but they may be communicating with their change in behavior. And so that's something to watch closely. And again, they may have difficulty with self-report. Some people may have difficulty with sort of reviewing themselves, doing introspection, looking inside themselves, and sort of saying that acknowledging that they're anxious or that they're feeling sad. And so again, it may not be something that they're able to then share. And again, we talked about the impulse control issue. So when we're screening, we certainly want to screen for behavioral changes, and certainly in our practice, we do that at least on an annual basis. Look for behavioral changes and any change in the routines or other changes that might suggest that there's something going on that we want to further look into. And again, as I mentioned before, the physical health conditions, making sure that we're looking to see, is there an underlying physical health condition that may be contributing? So it's so important. Again, any and all behavioral change should be considered a possible communication tool. And oftentimes that is a communication of an underlying physical health issue. So if someone is feeling pain or doesn't feel well, that they have an injury, or they have celiac disease, they don't feel well, or they that they're not normal in their physical health, and they're not able to say that again, that might be displayed with a behavioral change. And so they're very important to look for those underlying physical health conditions that might be contributing to a behavioral change or a mental health change. Treatment often is multidisciplinary. Either there might be a therapist or a counselor. We're fortunate to have both a licensed clinical social worker and an occupational therapist who do a lot of work with the individuals that we see to help them kind of better understand what's going on with themselves, as well as to try to help get them functioning again in day-to-day life. And then at times the medications will be part of the treatment as well. So in the guidelines, the global healthcare guidelines, what the recommendation was, when there is a concern for mental health is present, refer to a clinician knowledgeable about the medical mental health disorders and common behavioral characteristics of adults with Down syndrome. And I know that that's not always easy to find somebody. And I think certainly reaching out to other families and other people and finding who they've had success with is very important. But also that the medical professional should evaluate for medical conditions that may present with psychiatric and behavioral symptoms, as I've kind of said several times, because it's such an important point. So again, if the person looks depressed and we don't look for the thyroid abnormality, which an underactive thyroid can cause depression, we're really going to very likely miss part of the cause, at least part of the cause, and our treatment is more likely to be unsuccessful. So very important to look for those underlying physical health conditions. And then the other thing is to look at, how I've mentioned that it can often present more with behavioral change or an observable behavior rather than a self-report of symptoms. And so the DSM-5, or the Diagnostic and Statistical Manual of Mental Health Disorders, is sort of the diagnostic guide to mental health conditions. And that there's a modified version called the DMID-2, which is the Diagnostic Manual for Intellectual Disabilities. And if you read through the DMID-2, you will see that it's very similar to the DSM-5, except the difference is that some of the self-reported symptoms are taken out and replaced by observable behaviors. And so again, that's not an uncommon issue with mental health conditions and people with Down syndrome, that there may be more observable components, behavioral components to this than there are self-report components. But very important to consider those possibilities. So, okay, brief case study: a 22-year-old man who aged out of school and started to gain weight, and it had previously been a very pleasant individual and developed a disagreeable mood. And he also had difficulty sleeping. And so we again, very important to do the good medical history and do a physical exam and do appropriate labs. And in his case, because of the sleep changes, and we know that sleep apnea is more common in people with Down syndrome, we did a sleep study. The sleep study was actually normal, did not show sleep apnea, but ultimately we diagnosed him with depression and then sleep changes related to the depression, but not due to sleep apnea. And so again, he had aged out of school, and it was very important to get him into some new routine because he had lost his routine. And so that was the initial part of the treatment, and got him some counseling with our social worker. And again, these are not one individual; these are cases all sort of a conglomeration of other people. So there's nobody that I'm really speaking of directly, or that you might think that we're sharing personal information. So these are no one individual in these cases, I should say. But anyway, so again, this person got counseling and we established a new routine, but he still struggled, and so we ended up using an antidepressant for depression. And again, he was doing much better, but still having some difficulty with sleep. And so, in addition to we went back and looked at the routine with regards to sleep, and really worked on sleep hygiene, to a good night. You having a routine before bed, not looking at screens, the computers or the cell phones before going to bed, and other sleep hygiene approaches, and still was having some trouble sleeping. So we added medication that we use sometimes for sleep called trazodone, and that really got him back on track. Unfortunately, graduating school can be challenging for some of our folks with Down syndrome, because sometimes the next steps, the jobs and the things are not available, and so there's unfortunately sometimes some sitting around that becomes very challenging for individuals. So this is unfortunately not an uncommon story. All right, we're going to shift gears to look at endocrine conditions. And so that includes hypothyroid, underactive thyroid, which is significantly more common in people with Down syndrome, and hyperthyroidism, or overactive thyroid, and type 1 diabetes, and gout, not probably technically an endocrine condition, but we lump it in here. These are all more common in people with Down syndrome. And at least in our study, type 2 diabetes was less common. So the diabetes that we tend to get more as we get older and related to being overweight or obese. And at least in our study, type 2 diabetes was less common. A similar study done in the United Kingdom came out a year or so after ours, and they found that type 2 diabetes was more common than people from about their mid-20s to their mid-50s. But at least in our study overall, it was less common, which I have a little hard time understanding our data in the sense that it is what it is, but because it is associated with obesity, and we do know that people with Down syndrome tend to have more problems with obesity. And so a number of endocrine conditions are more common. And a lot of this probably has to do with not so much the gout, but the others probably have to do with autoimmune conditions. Autoimmune conditions are more common in people with Down syndrome. And autoimmune conditions is in which the immune system, in a sense, attacks a part of the body. And so in adrenal insufficiency or Addison's disease, typically the immune system in people with Down syndrome will have their adrenal glands. The immune system will disrupt the function of the adrenal glands. And similarly, with an underactive or overactive thyroid, hypo and hyperthyroidism, the adrenal gland, the thyroid gland is attacked by the immune system. And you can see the thyroid, almost hypothyroid, underactive thyroid being almost 11 times more common in people with Down syndrome, and hyperthyroidism, overactive thyroid being about 2.5 times more common. Hashimoto's is one of the types of hyperthyroidism and a contributing cause of hyperthyroidism, as is Graves' disease. You can see both of those are more common. And the gout, again, being a separate category, but where uric acid crystals form in the joints and cause a severe inflammation of the joint. And again, we see that significantly more common in people with Down syndrome than in others. A condition called diabetes insipidus, which has nothing to do with blood sugars, but has to do with how our kidneys retain sodium or salt, is more common in people with Down syndrome. And again, we mentioned the type 1 diabetes being more common in our patients, and type 2 being less common. And what are some of the issues with that might little differences in the data from the UK. And again, as far as how it presents, again, because of self-report issues and communication issues, sometimes it'll present more with a behavioral change or a psychological change. But then there also can be some physical symptoms as well that's specific to the condition. From the healthcare guidelines, it's recommended we screen for thyroid every 1 to 2 years and diabetes every 2 to 3 years. And then the treatment generally is similar. Although we do find that some of our individuals, when we're treating particularly underactive thyroid, that some individuals, if we get the thyroid values normal, they seem to, at least perceptually, they seem to almost as if they're on too much medication, even though the lab values are normal. So some people, one of the symptoms of an overactive thyroid or being on too much medication is anxiety. And so we've seen some individuals, when we get the lab values to the normal range, they actually become more anxious. And so we have to adjust to, make it just barely normal or maybe just a little under normal in order that they tolerate the medications. But again, that just depends on the individual, and that's not true universally or even in a large percentage. Most people get the values within the normal range, and they do well. So from the Healthcare Guidelines Project, the global guidelines for people without symptoms, begin at age 30, screen for type 2 diabetes mellitus using a hemoglobin A1C, which is a blood test, or a fasting plasma glucose, a blood sugar test every 3 years. And for adults with Down syndrome who are obese, in the obese category, beginning at age 21, it's recommended to screen for type 2 diabetes, again, using the same blood tests every 2 to 3 years, so starting at a younger age and perhaps more frequently. And then the thyroid recommends screening for the thyroid every 1 to 2 years, beginning at age 21. And we're just using 21 because this talk is about adults. but certainly there are guidelines for children as well from the American Academy of Pediatrics that would cover the younger age. And similarly, it's recommended to screen for thyroid in kids as well. As far as obesity, we really want to continue to monitor for weight change and obesity annually by calculating the BMI and following general guidelines to help with weight loss. Again, certainly being overweight or obese is more common in people with Down syndrome, but it's not inevitable, and something we really want to continue to work on. Not a long enough presentation today to talk about medications or other interventions for weight loss, but again, certainly trying to be aggressive and keeping the weight within the normal range is important. And again, using a comprehensive approach to weight management is very important to try to help people with maintaining a healthy weight. Talk a little bit about infections. So things that are more common include pneumonia or skin infections. There's a number of skin infections that are more common. Interestingly, in our study, influenza or flu was less common, which I was a little surprised at, as were upper respiratory infections. Again, not clear why that is, or perhaps since pneumonia was more common, perhaps more of our individuals that developed these infections went on to develop pneumonia, and so perhaps the influenza or the upper respiratory infection diagnosis was not focused on. But in general, we know that unfortunately people with Down syndrome do have more respiratory infections, upper and lower. And certainly saw that during the pandemic when the COVID was significantly more common in people with Down syndrome than the rest of the population. And then sexually transmitted diseases infections are less common in people with Down syndrome. And some of that may be with likely regards to reduced sexual activity, which as the norms change and people are more involved in completely included in society, we may see that change over time. But again, you can see that some of the infections being less common in individuals we saw, and the pneumonia being significantly more common, and skin infections being more common as well. A couple of things that may present a little differently. Some of the individuals we see don't really mount fevers really significantly. Certainly many do, but some don't. So there may be a lack of fever, so that may make it a little more confusing with regards to diagnosing an infection. Some individuals with Down syndrome have a very low white blood cell count to start with. And so the white blood cell count, when it goes up, may not go up out of the normal range. And so they may not have an elevated white blood cell count to collaborate or to confirm that they have an infection. Many people with Down syndrome tend to have a lower blood pressure always. And so if they get a bad infection, which is causing their blood pressure to go even lower, it may get into a significantly concerning range more rapidly because they already start with a low blood pressure. And some individuals have, as I mentioned, the adrenal insufficiency, the adrenal gland not working as well. I mentioned in the endocrine discussion. And in the adrenal gland, it really kicks in when we're under stress. And one of the stresses is sepsis or a bad infection. And so if the adrenal gland function is sort of borderline or low, we may see that the individual's body is not able to respond to the infection in the same way. And often that's manifested by an even lower blood pressure. And so just something to think about when we think about someone, when our individual that we serve ends up in the intensive care unit, for example, when they develop a bad infection, we want to make sure if their blood pressure is low and not responding to the usual treatments, that we really make sure we think about the adrenal gland and what the implications for low functioning adrenal gland may have with regards to treating their sepsis. Screening and treatment is generally similar. Potentially screening for sexually transmitted diseases, if the individual is not sexually active, may have a different recommendation. And let's go to gastrointestinal conditions. We know that reflux or heartburn is significantly more common in people with Down syndrome, as is celiac disease. Celiac disease being the sensitivity to gluten, which is a protein in wheat, barley, and rye. And the things that are uncommon, it's a little hard to know for sure. again, a lot of the gastrointestinal conditions for all of us are a lot to do with self-report and being able to provide a history of what's going on with how we're feeling. And again, some individuals with Down syndrome are not able to do that well, and so that sometimes can make it more difficult to know what we don't make it difficult to know what we don't know, and so that's a challenge. So again, so esophageal disorders like reflux are again more common, about 1.5 times as common. Ulcers we see more commonly. And then celiac disease is the big one there. More than 18 times more common in our practice compared to similar people without Down syndrome in the rest of our healthcare system. So celiac is a big one. So again, how does it present? So again, some people with Down syndrome, they have difficulty, excuse me, difficulty expressing their pain or telling us about their pain. So that sometimes maybe change the presentation. They may not, where someone else may have a significant pain component, and the individual with Down syndrome may not be sharing that. In reflux, for example, in chest pain, that's a common symptom with heartburn. But again, that may not be something that someone tells us about. And also, we're going to talk about heart disease here in a second. Heart attacks are much less common in people with Down syndrome. So chest pain is something, when I think about it, I don't negate the possibility that it's a heart-related problem, but in our practice, it's much more likely to be heartburn or reflux. Again, sometimes the person is not able to share that they're having some discomfort, and so that it's actually a change in function or a change in mood or behavior. And so those are all things we have to think about when we're when we see these changes. Could there be a gastrointestinal complaint going on that the person is not able to tell us? And then we mentioned that the screening colon cancer being significantly less common. And many of our individuals that have to have colon cancer, or if they have to have anesthesia to do a colonoscopy. And so that's, again, we talked about the shared decision making. Does screening for colon cancer make sense in that individual? And that's something to discuss with your provider. I say that I probably do way more abdominal evaluations, meaning imaging or scopes or x-rays or CAT scans or whatever in our practice, because so much of diagnosing abdominal complaints is based on the history. And if the individual is not able to give a good history, it does make me need to proceed forward and try to get the answers in other ways. In general, the treatment once diagnosed is similar. But again, we mentioned during the mental health part that, getting people, having our occupational therapists help people get functioning again. Sometimes people, after they've had gastrointestinal problems, have more fear or less likely to want to get involved in activities again. And so sometimes that's got to be a component of it to help them get going again. In the global guidelines, it's recommended to do an annual assessment for gastrointestinal and non-gastrointestinal signs and symptoms of celiac disease. There are not studies that support doing blood tests annually or even regularly to screen for celiac disease in people with Down syndrome. But we do know that the classic symptoms of celiac, again, this sensitivity to gluten, that the classic symptoms are weight loss and diarrhea. But we also know that the number of symptoms that can be caused by celiac disease is very, very large, from not feeling well to some of the people we see, just having a change in behavior because they're not able to report they don't feel well. It can be even things like seizures, and I mean, the list is very long of symptoms that celiac disease can cause, skin problems and other things. So why we don't screen every person every year for celiac, we're pretty lenient on when we'll be getting blood tests that's assessed for celiac if anyone presents with a symptom that could be suggestive of that. And so that we do end up doing a fair amount of blood work for testing for celiac, although we don't do it on everybody every year, per the guidelines. So again, just a case study, a 21-year-old man with a depressed mood and reduced or impaired verbal abilities And then he has a change in his ability to complete his activities of daily living. So again, always start with a good history and physical exam, appropriate blood testing, and then an occupational therapy assessment on why he wasn't able to do his activities of daily living as well. And he ended up being diagnosed with celiac disease and vitamin B12 deficiency, which can cause depressed mood, amongst other things. And he ultimately also had developed catatonia, which we'll talk about here in a second, with the Down syndrome regression disorder and regression and depression. And so his treatment was, again, because of the celiac, put on a gluten-free diet, and we had occupational therapy to get him going again, and then appropriate medications. So you can see from this, sometimes it ends up being more than one thing, and really wanting to make sure we're addressing all the components to make sure that we can optimize the chance that the person is getting better. So let's talk a little bit about some neurology and orthopedic conditions. So seizures are more common in people with Down syndrome, as is unfortunately Alzheimer's disease. And unfortunately, seizures are more common in people with Down syndrome who develop Alzheimer's disease as well. So that there's kind of two reasons people have more seizures. Cervical myelopathy, which is injury to the spinal cord, and a common reason for that in people with Down syndrome is atlantoaxial instability, where the first vertebrae slips on the second. And you may be familiar with that with Special Olympics. Then everyone has to be assessed. Everyone with Down syndrome has to be assessed for atlantoaxial instability before they can participate in Special Olympics. And then osteoarthritis we think is probably more common in people with Down syndrome. Uncommon, we see less atherosclerotic strokes. So strokes where we develop a plaque or a narrowing of the, for example, the artery in the neck or in the brain, around the brain. We tend to see that less in people with Down syndrome. Multiple sclerosis, we have one possible case in 32 years, which is a little interesting because there is an autoimmune component to that. Why we don't see more multiple sclerosis, I don't have the answer to that. And similarly, we don't clearly see Parkinson's disease, although some individuals that develop Alzheimer's disease will have some Parkinson's-like features. But we really have not seen very many people that actually were diagnosed with Parkinson's disease. And you can see here some of that epilepsy or seizures are about 5 times more common. Alzheimer's disease and the comparing across age, similar ages, significantly, almost 37 times more common. And again, injury to the spinal cord, again, often due to atlantoaxial instability is more common, as is atlantoaxial subluxation, the atlantoaxial instability, that first vertebrae in the neck slipping on the second, you can see is almost 80 times more common in people with Down syndrome. And then osteoarthritis, a little more common. And so how do things present? Again, with osteoarthritis, oftentimes, again, because of individuals not reporting pain, we may see that this present more of a change in function, so that the person's hip isn't working as well, or their knee, or their hands for that matter. So we pick up on it because of a change in function rather than a complaint of pain. Atlantoaxial instability, again, oftentimes it's not complaining of neck pain, oftentimes will be a change in their function because of the spinal cord gets pinched, where the individual will not be able to walk as well, or will develop some incontinence, or have difficulty holding things because their arms or hands are weak. But sometimes people will just, again, they're experiencing these changes and they can't explain it, and they can't really share with what they're feeling, and so they end up with a change in mood as how this presents. And then Alzheimer's disease often presents with, not universally, but commonly presents with the first symptoms being psychological or behavioral changes. So as individuals get older and they start to develop some of these changes, considering the possibility that there's Alzheimer's disease is important. As far as screening, certainly want to screen every year for atlantoaxial instability. We'll talk about that in a second, as well as Alzheimer's disease. And the treatment, particularly for Alzheimer's disease, we unfortunately don't have data that really supports using the medications at this point for Alzheimer's disease in people with Down syndrome. And then again, seizures, we want to make sure we're treating the seizures because particularly because they have a higher prevalence, a more common, particularly in people with Down syndrome who develop Alzheimer's disease. So the guidelines, screening for the atlantoaxial instability. Again, in the past, it was recommended to do routine neck x-rays. But at this point, the recommendation has changed in the guidelines, both in the pediatric guidelines and the adult guidelines, that routine x-rays are not recommended. But reviewing each year with a good history, looking for symptoms that suggest the spinal cord is being pinched, and also doing a good exam, a neurological exam, to look for symptoms of spinal cord impingement, and then if there's any abnormalities, to do imaging at that point. In fact, the Special Olympics has taken out the recommendation to do regular neck x-rays in people with Down syndrome. And then one other condition is osteoporosis, really, or thinning of the bones, which is more common, particularly in women as we get older. But again, how frequent this is in people with Down syndrome is really not clear. And if people with Down syndrome do have osteoporosis, really has not been shown that. I mean, really, the big concern of osteoporosis is developing fractures. And so there really isn't data to show that people with Down syndrome have frequent fractures as they get older related to osteoporosis. So there really is a lot we don't know about this. And so at this point, it's worth a discussion based on what the guidelines, but we don't really have a clear understanding of this problem in people with Down syndrome. And there is some question whether what's called the DEXA scan, which is a typical test used for osteoporosis, measuring osteoporosis. There's some question whether that is as accurate in people with Down syndrome as it is in other people. So there's a lot we don't know about this, unfortunately. However, if someone does get a fracture in an older age, that suggests the possibility of osteoporosis, we certainly want to go looking for other causes that might be contributing to that, whether that be vitamin D or abnormality in what's called the parathyroid, which are small glands next to the thyroid gland. Whether there's medications the individual's taking that may be contributing to that. So all things that we'd want to take a look at. And then lastly, the guidelines, the global guidelines, it's recommended for adults with Down syndrome younger than age 40 that we be cautious when diagnosing age-related Alzheimer's dementia. We know that people with Down syndrome, pretty universally do get the changes in the brain associated with Alzheimer's disease. But onset of symptoms tends to be uncommon before age 40. And so particularly if someone's declining before 40, has some cognitive decline, we really want to go looking for something else and not just assume that it's Alzheimer's disease. Even after age 40, we want to make sure we're looking for other things that could be causing that. But it is recommended by the guidelines starting at age 40 that we begin to screen every year for looking for any changes. And one potential screening tool is the National Task Group Early Detection Screen for Dementia, the NTG-EDSD. And we have a link there to that screening tool. It's about a 6 or 7 page document that goes through a number of functional changes that you can kind of do on an annual basis, or even more frequently, as the case may be, to look for any changes that might be suggested that the person needs further assessment for a dementing process or some other underlying cause. All right, we're going to jump one more time, and this time to heart disease. Limited data, but there are data that indicate that people with Down syndrome have a higher risk of embolic strokes. And embolic strokes are strokes that are caused when a clot breaks free, typically from inside the heart, and goes to the brain and causes a stroke. And that seems to be likely related to having congenital heart disease in people with Down syndrome. So those that had heart disease as an infant, even if operated on and fixed, those people do seem to potentially have increased risk of embolic stroke down the road. Also, there's something called Moya-Moya disease, which is more common in people with Down syndrome, which is an abnormality in the structure of the blood vessels, particularly in the back of the brain, and can cause strokes. And that typically presents in childhood. We see very little high blood pressure or hypertension, and again, very little coronary artery disease or heart attacks, myocardial infarctions. And you can see how high blood pressure, hypertension, very uncommon, 0.04 or 0.04 times as common in people with Down syndrome. Strokes, you see a little bit more as we noted, and again, moya being significantly more common. Coronary artery disease, again, the hardening of the arteries or the plaques in the arteries, significantly less common in our studies. And again, hypertension you can see, but again, the risk factors of overweight and obesity being more common. So there's clearly components to this that we don't have a full understanding of at this point. Again, we have a limited experience, and because we had so few people present with heart attacks or things like that. But one thing to consider is the possibility, again, that it may not be a complaint of pain, that there may be a presentation with a change in function. And then as far as screening, we'll talk about cholesterol and high blood pressure here in just a second. So in the guidelines, it was recommended that for adults with Down syndrome without a history of atherosclerotic heart disease, without previous history, that it is probably appropriate at age 40 to check for a cholesterol level at every 5 years starting at age 40. And then there's something called a 10-year risk calculator, which is recommended for use in other people as well. And to use that calculator to determine if the person with Down syndrome, there's certain scores that come out of that, and whether the person with Down syndrome should be considering use of a medication like a statin to reduce the risk of heart disease. As far as the strokes, again, we tend to see less strokes where the hardening of the arteries or the plaques, but we seem to see more related to congenital heart disease and the long-term complications of that. And so the guidelines recommended that people follow up with a cardiologist on a regular, who've had heart disease as an infant, follow up with a cardiologist on a regular basis to look for other potential complications that could arise, that could increase the risk of those strokes. So a 45-year-old man presents to the emergency room with chest pain. Again, do a good history and physical exam. He had a normal EKG, and the blood work was negative for a heart attack. He was given antacids, which treated his reflux disease, his heartburn. And then we had a discussion about the lower incidence of heart disease, atherosclerotic heart disease in people with Down syndrome, and whether he should have additional workup with regards to a stress test or something to further assess. But again, much more likely in our patient population experience that this was related to heartburn rather than a heart attack. Just some other real quick topics. Swallowing issues we see more common in people with Down syndrome. Significantly more vision, wide variety of vision problems. We won't go into great detail, or hearing problems, and then sleep apnea. Sleep apnea is going to be part of the next round of the healthcare guidelines, so we'll have more information on that in the coming years. Things we're not sure, are they less common, or are the people just not complaining about them? Chronic pain, headaches, back pain. These are complaints we get very infrequently. And so, again, hard to know for sure if that's less common or whether that's people are just complaining about them less. And you can see some of these things that are the swallowing issue, significantly more common in sleep apnea. I suspect sleep apnea is even more common than that. It just, a lot of the individuals we see have difficulty getting a definitive diagnosis because they have a hard time cooperating with this sleep study. And again, it may present as a behavioral change. And there may be, for swallowing, there may not be any real complaint of that until they develop a pneumonia. And we do see a number of folks that the swallowing is not just in their mouth and the throat area, but there's implications with regards to their esophagus not working. So if swallowing is an issue and you're not finding other reasons for it, consider the esophagus. And again, sometimes people just present with a decline of skills, particularly with sleep apnea, that there may not be any other symptoms other than they're just not functioning as well. As far as screening for sleep apnea, it's recommended that all kids around age 3 get screened for sleep apnea. There is, again, we'll be looking at that with this round of guidelines. So there's not a clear guideline on screening for sleep apnea, but it's certainly something we ask about in the appointment and have low suspicion, referring people for sleep studies if there's any other change, mood changes or skill changes, because that can affect all those things. And so a 29-year-old woman with psychosis and more rigid adherence to groove, she became, more compulsive, if you will. Again, a good history of physical and lab tests. We ended up diagnosed with sleep apnea and obsessive compulsive disorder, and her symptoms improved with the CPAP for sleep apnea, but also she required an antidepressant for the obsessive compulsive condition. And even though she had psychosis, she did not require an antipsychotic medication because the sleep apnea was significantly contributing to that, and those symptoms resolved with treating the sleep apnea. And we've given other presentations on Down syndrome regression disorder, have others, so I'm just going to be very brief on this. It's also referred to as Down syndrome disintegrative disorder or regression or adult regression syndrome. There isn't an official name yet, although Down syndrome regression disorder has become sort of a agreed upon name. We have limited information on how frequently it occurs. It's that's thought to be really common, but it is not uncommon either. It certainly needs to be continued to be studied and discussed. There was a consensus paper that came out a couple of years ago. 27 panelists who had previously published on regression and Down syndrome were involved in national or international working groups. Came to some assessment or a consensus, I should say, on assessment and diagnosis, and also a name, and that's where the name Down syndrome regression disorder came from. Although again, it's not an official name that is accepted by the insurance companies, for example, or Medicare. The symptom onset is new neurological or psychiatric or mixed symptoms over a period of less than 12 weeks in a previously healthy individual with Down syndrome. And you want to look for other causes, certainly. And there's a wide variety of symptoms, change in mental status or behavioral regulation, cognitive decline, regression with or without autistic-like features, sometimes focal neurological deficits on exam or seizures, sleep changes, language changes. Some people will develop movement changes, and often psychiatric symptoms are a component of it as well. Again, because there's not an official name and an official ICD-10 code for this, as close as we have in our because catatonia is such a common feature of it, when we went back and looked at that, we saw that catatonia was significantly more common in people with Down syndrome. And I can't recall diagnosing anybody in our practice with catatonia that did not have Down syndrome regression disorder. So it just kind of gives an idea that this is significantly more common in people with Down syndrome. And then lastly, I think it's important to consider co-occurring conditions. And what I mean by that is some people will have more than one thing going on at the same time. And that's important to think about those things, if particularly people are not getting better with the diagnosis and treatment of the initial problem. So a 51-year-old woman with decreased attention to the groove, so she's not attending to her tasks as well as she did before. Again, a good history in physical and lab tests, and she was diagnosed with an underactive thyroid, but also had some memory impairment, challenges with depth perception, difficulty completing multi-step tasks, and we diagnosed her with Alzheimer's disease as well. So again, you don't want to overlook the thyroid because that can help improve function as well. But also she had Alzheimer's disease, so you really want to address both. And again, we talked a little bit about medications for Alzheimer's disease. Again, to help her with her function, we did physical therapy and occupational therapy, and got her some adaptive equipment to optimize her skill levels. So what are the takeaways? We want to leave some time for questions here. So people with Down syndrome are living longer and healthier than ever before. Some health conditions are more common in people with Down syndrome and some are less. Thorough evaluation is recommended to assess for conditions that may present as a behavioral change. If you take nothing else out of today's talk, take that one line, that how important that is. And ongoing research and review of the literature will help us decide on appropriate screening, diagnosis, and treatment of these co-occurring conditions in people with Down syndrome. We do have some resources to share, and I am going to turn it over to Laura.
Thank you so much, Dr. Chicoine, and thank you to all our attendees who have submitted questions. We're going to try to address as many of them as we can, but I strongly recommend that you take a look at our online resource library. There is a lot of information that would answer some of the questions we've gotten. on the resource library. All the resources there are available free of charge except for resources from other organizations. All right, I'm going to dive in. We've gotten some questions about whether you can develop celiac disease and atlantoaxial instability later in life.
Yeah, both of those conditions can occur anytime through life. And the other thing, in addition to atlantoaxial instability, some people later in life will develop osteoarthritis in the neck. And part of osteoarthritis sometimes is little bony outgrowths from the bones. And those can also pinch on the spinal cord. So that even if they haven't developed atlantoaxial instability, some people will develop symptoms that are suggestive of atlantoaxial instability based on the spinal canal being narrowed by these bony outgrowths. So absolutely, you want to consider both of those conditions if someone presents with symptoms that are suggestive of those in an older person, both celiac and atlantoaxial.
Thank you. Are immune disorders more common in people with Down syndrome?
Yes, the immune system, unfortunately, doesn't work as well against infections, but sort of works overtime when it comes to autoimmune conditions where the body's attacking it, the immune system's attacking its own body. So those conditions are more common in people with Down syndrome.
Thank you. And then is alopecia common, and what's the common treatment, and would it ever go away without medication?
Yeah, alopecia or loss of hair is more common in people with Down syndrome. And it's now becoming clear that there is very likely an autoimmune component to that. And so really the treatment has kind of shifted to looking at autoimmune treatments. And there's actually a study going on right now in Denver. We're looking at using medications to suppress the immune system to treat alopecia, and they're having some success with that. So that is a significant change in the treatment over the last several years.
Thank you. There are weight charts specific, or growth charts, I'm sorry, specific for children with Down syndrome. Are there similar charts for adults?
There are not. I mean, so we're kind of left with the BMI, the body mass index, is sort of the indicator of whether someone's overweight or not. Not a great measurement, really, frankly, for any of us, but and even more challenging what the implications are for people with Down syndrome. So, but it is all we got. It is what we have at this point.
Thank you. Would you mind talking a little bit more about anesthesia and the risk of complications from anesthesia?
Yeah, so based on the physiology of people with Down syndrome as well as the anatomy, there are some potential for complications, whether that be swallowing issues or heart rate changes or aspiration, as someone comes out of anesthesia, or because of reflux issues, heartburn issues, if acid gets refluxed out of the stomach up into the esophagus and then gets aspirated into the airways, all those are potential issues to make sure that the anesthesiologist is being aware of. As far as atlantoaxial instability, it's really recommended that all people with Down syndrome, when they undergo general anesthesia, be treated as if they have atlantoaxial instability, because if you tilt someone's head back to put the breathing tube into their throat, you could actually cause some spinal cord impingement. So it's recommended that doing X-rays ahead of time really is not a good enough screening tool, and we really just ought to treat everyone as if with Down syndrome as if they have it when they undergo anesthesia. And so there are ways that the anesthesiologist can actually visualize the vocal cords with a scope rather than tilting the head back. And there's a very nice, I forgot to review this slide, but there's a very nice, if your healthcare provider has any questions about that, there's a very nice presentation on the Down Syndrome Medical Interest Group on anesthesia for people with Down syndrome that you might be interested in taking a look at.
Thank you so much. Would you recommend metformin if weight is becoming a problem for a person with Down syndrome who's otherwise healthy in their 20s?
Yeah, metformin is one of the options for weight loss, to help with weight loss. It's also an option for someone that's developed pre-diabetes, so their blood sugar is a little elevated, but they have not actually gone into the range of having diabetes. And there is data in the non-Down syndrome population that taking metformin can actually help prevent that person from converting over into actual type 2 diabetes. We have tried it. I would say that I've not been overly impressed with its effect on weight or weight management, frankly. Some people say they have a little better success with it than I've been impressed with, but it is an option.
Thank you. Could you talk about the link between hypothyroidism and depression, please?
Yeah, so for any hypothyroidism, underactive thyroid, for any of us, one of the symptoms of an underactive thyroid can be depression. And so whether you have Down syndrome or not, that is a potential symptom of an underactive thyroid. And so when people with Down syndrome, any person that we're concerned has developed depression, we are looking for their thyroid, because it's even more of an issue in people with Down syndrome, because so many people with Down syndrome have an underactive thyroid. And so we really want, whether that explains the whole thing or whether it's just part of it, we want to make sure that that is treated appropriately as part of addressing depression in people with Down syndrome.
Thank you. How would you suggest we encourage more medical students and healthcare providers to learn more about Down syndrome so that they can provide comprehensive, competent care?
Yeah, there's a lot of things going on right now in this country with regards to adding education in the medical schools, residencies, and then certainly looking at how we can support healthcare provider, people already in practice as well. So again, I would encourage you to, if you have a healthcare provider that you think would benefit, I would encourage you to share the Down syndrome medical interest group information with them. We have a speaker series. We have something called Project Echo, where a provider can, or a healthcare professional can present a case to a panel of experts via a Zoom meeting, and it's all de-identified. So the person is not identified. The patient, if you will, is not identified. But then the panel of experts shares that information with, shares recommendations with them, and then the healthcare professional is able to take that information back home in a sense, and then treat that individual. So I really encourage you to share Down syndrome medical interest group with your healthcare professionals.
Thank you. We've gotten some questions about constipation and dry skin. We do have a webinar recording that Dr. Chicoine did on at-home treatments for common health conditions, and both constipation and dry skin are addressed in that. And I'll include the link to that webinar in the email that goes out with the link to this webinar. And we also have gotten a lot of questions about pain. Is there anything you would want to share about pain?
Yeah, we just recently put a new post up on our new document on our webpage about pain. Pain is a kind of a tricky thing in people with Down syndrome, and I think our understanding, I know our understanding has evolved significantly since we started doing this 32 years ago. So oftentimes people will report that a person with Down syndrome seems to have a high pain tolerance or a low perception of pain because they'll have a painful condition that they're not reporting. It now seems that those individuals probably are perceiving pain, and again, they may have difficulty reporting it. They may have difficulty localizing it. So they injured their ankle, but they're having a hard time saying that it's their ankle that's bothering them. And sometimes people have sort of a delayed perception or delayed response to pain. So it can be tricky, but it is clear that people with Down syndrome do seem to have perceived pain. And so we really, it behooves us to, just look that much harder particularly if there's a change in function or a change in behavior, that there may be something that's causing pain that may be contributing. So I would encourage you to take a look at that article. Certainly my thinking on pain has changed dramatically in 32 years, and we tried to do a good summary of that in our recent article we posted on our website.
Thank you so much. We are at 12:15 Central Time, which was the ending of our webinar. So we want to thank everyone for joining us today. If you could go to the last slide, please. Keep going past the references. Yep. So we have all those references for you. And then we are able to offer this webinar free of charge through the support of generous donors. So if you're interested in supporting the research and education program of the Adult Down Syndrome Center, please see that link. And we will be sending the links to this webinar recording, the links that were shared in the Q&A, as well as a link to the slides within about a week. So thank you all for joining us, and we hope you have a great rest of your day.
Thanks very much for joining us.